So that tells you where my rank was.
Yes, well, I was not interested in being saluted to.
Yeah.
Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend some time with us as we explore the issues surrounding the COVID pandemic and other issues affecting the communities of color, especially expressed as health disparities. We are blessed today to have as our speaker, Dr. Doris Brown, retired Colonel, Army Medical Corps, who is an internist / oncologist who is very well versed in the area of breast cancer. And we will focus much of today's discussion around that. But without more ado, let me turn the reins over to our founder, Dr. Randall Maxey.
Thank you, Dr. Neighbor Stevens, and I appreciate all of our special guests. And Dr. Ivan Walks, who is our co-moderator, along with Dr. Neighbor Stevens, and our newest addition, Dr. Jocelyn Hines. I appreciate you. And Dr. Walks is going to take me on a lunch date in a couple of weeks. I get to see a pro football game. I'm looking forward to that. I'm very seriously aware of the impact that's happening with this COVID-19, but especially the fact that it's taken so much over of our attention that many of the things that normally put us at risk have been placed down in second and third place, and we don't pay attention to our daily health. There's more to life than just COVID-19. And we have to look at our health overall. And today we're going to have an experience with something that many of us have not thought can affect such a broad range of communities of color. So I'm glad to have a fellow former past president of the NMA as our guest today. Dr. Ivan Walks is in charge of our task force for vaccines. Dr. Jocelyn Hines is a noted family practitioner, ER doctor in Maryland, and my constant sidekick and fellow chef, Dr. Neighbor Stevens, are going to lead the questioning. Dr. Neighbor, please introduce our special guest a little bit. You did some already, but bring her on.
All righty, it is my pleasure, and I am so appreciative of our guest being able to share a few moments with us this afternoon. She is an outstanding physician. She is a compassionate person and a joy to know and work with. Without Dr. Brown, Dr. Doris Brown is a former president of National Medical Association. She is a proud graduate of Tougaloo, and we'll quickly let you know about Tougaloo. Without further ado, I turn it over to Dr. Doris Brown.
Thank you so much for the introduction. And yes, I always have to highlight Tougaloo and HBCU in Mississippi. It's very important that we lift up our HBCUs because they are graduating the majority of our professionals in this country, and they don't get the recognition. I did the majority schools in terms of medical school and a master's in public health, but yes, I'm always touting the HBCU. But this day we are talking about breast cancer primarily because this month is Breast Cancer Awareness Month. And it's really important for us to speak about breast cancer because as Dr. Maxey has indicated, we've been caught up in the COVID era, and we tend to forget about some of the other things that are really important and also leading to our continuous increased mortality rate. So let me just give you some data and know that statistics are just numbers, and until it applies to you, it's a number. When it applies to you, it's 100%. But just to give an overall picture of what breast cancer is, it's the second most common cause of cancer death in women. That is second to lung cancer. It is one of the most diagnosed cancer types that we see in women outside of skin cancer. And they estimate, and this is data taken from the American Cancer Society Cancer Journal, that really overall each year look at estimated numbers of women that are going to be diagnosed with breast cancer, and also the mortality rate. So for 2021, they're estimating that there will be about 281,500 women with a diagnosis of invasive breast cancer, and nearly 50,000 will be diagnosed with non-invasive breast cancer. And probably some in the audience have heard that it's DCIS, mean diagnosis in situ, that yes, it hasn't fully developed into that invasive breast cancer. But I also want to point out that men also get breast cancer, because I think that is something that we tend to overlook and forget, but about 1% of the breast cancers occur in men. When you look at the death rate, you have about 44,000 deaths are estimated to occur this year for breast cancer. That is about 500 plus for men and about 43,600 for women. When you start to look at survival after you've been diagnosed with breast cancer, and I should say a large majority of those breast cancers are non-metastatic. So that means it's limited, it's localized. And that's at probably about 90%. So you estimate that those individuals with treatment could live longer than 5 years. And then we also estimate a 10-year survival, and that is following diagnosis and treatment that I'll go into in just a bit. And that number is still in the 80-85%. Know that the numbers that I'm stating has greater applicability to the majority population, even though the majority population is becoming the minority population. And I like to say the non-hued population. And when we start to look at what is happening in the BIPOC community, you're going to know that that number is going to be a lot less for us in terms of our survival. We know that, and I'll just say African-American or Black women do not get the diagnosis. The incidence of the new cases of breast cancer is lower than it is in whites, but we die more than the white population. And that has to tell you something in terms of when we are diagnosed and the treatment that we're going to get, the associated conditions that we have. All of these impact how we are going to survive. And so, again, we probably at about 10% survival is lower for Blacks than it is for whites. And also, when you look at the cancers that are spread, are metastatic outside of the breast and the lymph nodes, we're going to say that that number is really at about 6%. But for Black women, that number is going to be higher. And so again, what is the cause of those conditions? Why is that so? Delay in diagnosis. We do not get the screening that has been recommended. There are guidelines that are known and have been known for years, even though we argue have a lot of controversy centered around whether you should get a mammogram and who should get it and when should they start. And that goes back and forth every few years. They'll say, oh, yes, you should start. Years ago when I was in training, it was women should get their first mammogram at age 50. Well, we now know that for Black women, you're getting a diagnosis much earlier because you're finding those lumps. And so the number has gone down, and most of the larger organizations have recommended that you start at age 40. However, there is a condition, a breast cancer subtype that I should say, called triple negative breast cancer. And that created a lot of interest a few years ago, and everyone was, oh my goodness, there's this very aggressive cancer and it's spreading and we don't know what it is. And so, yes, it tends to occur in women that are young, in women that are Black, and in those that have what has been identified as the breast cancer gene. It's called BRCA, BRCA1 and BRCA2. Those genetic markers are well known. Usually you see them in Ashkenazi Jews. And so again, they know that that is a very aggressive cancer, tend to run in those families. And then you want to make that diagnosis early and try to bring in the treatment and prophylactic therapies as well to make sure that those women are going to survive. So when this triple negative was identified, and of course we are always doing research to advance our cancer care along, and we, with the treatment, you have 3 types of treatment, whether it is surgery, radiation, or chemotherapy. And now we have a 4th one called immunotherapy. That is because we are continuing to do research and advance cancer care. So what we've seen is the number of women dying from breast cancer really decreased from the 1990s to about 2018. That number went down at about 41% higher in terms of that decreased death rates in whites as compared to Blacks. But overall, we have about a 1% decrease of death rate in cancers for women over the age of 50 since the 2018 timeframe. Of course, you're going to have some anomalies in there when we start to look at COVID and the impact on our treatment and our care. And so let me just say that with COVID, people were afraid to go to their healthcare providers. They put screening aside, and I'll show you a slide later on to just show you some of the kinds of things that happened when we looked at decrease in screening and the projection of what we're going to see in the future.
Dr. Brown.
Yes.
May I ask you a question about one of your statements?
Yes.
That we, meaning communities of color, are diagnosed at a later stage in disease. I wanted you to expand on that. Is this similar to the overall health hesitancy that we have in our communities? Is it the way the healthcare system is working, or the way that our communities are responding to their own health surveillance needs? Which is, or is it both?
It's a very complex situation. A lot of it has to do with what we've called social determinants of care. One, many of the people of color do not have primary care providers, and so they have not been following guidelines of getting treatments, et cetera. They live in environments that have been, I like to say, socio-politically impacted, so that they are more exposed to pollutants and have other kinds of negative socio-political determinants that are going to keep them out of the doctor. Some of them do not have insurance. Some of them may be afraid to get a mammogram in terms of it's painful or it's not easily accessible. So you have to look at a complex array of things to know that when they finally get that mammogram, it's going to be late. Now, part of also this controversy, we in the past have trained women to do breast self-exams, and they can do that monthly. Well, we now have another generation, and we know from a scientific standpoint, let me say at the outset, it has never been proven from a scientific standpoint where you do a study comparing people that do self-exams to those that don't, and that study is never going to be done, that there's not a scientific basis. But I can tell you, of the women that I treated, nearly 80% of them found that lump themselves. So doing breast self-exams is really important. And then you need to get that annual clinical examination and follow that with the mammogram. And so again, women that don't want to feel their breasts or don't want to have their significant other feel that breast, they don't have the relationship with knowing the lumps and bumps that's in that breast. And so if they happen to note a lump, then fear of going to their provider to find out what it is. So all of that leads to having their cancer that in many cases have spread beyond the breast to the lymph nodes and maybe in other parts of the body, because breast cancer can spread to all parts of the body. So let's talk about, well, this is not all gloom and doom, and I don't want people to think that, because we have nearly 4 million women that have been diagnosed with breast cancer that are thriving, alive and well, and doing all the things that they normally would do. And that is due to the kind of treatment we have, to their diagnosis, as well as some preventive issues that we have. And so I'll talk a bit about that. But let's go back and talk about risk factors. If you're a woman and you get older, you're at increased risk of breast cancer. So I am at high risk for breast cancer because I'm an old woman. And again, that's not something that you can do anything about. There are some things that you can modify. So we talk about modifiable risk factors, and easily things that really apply to other diseases that we have. We can exercise, we can watch our diet, we can really never ever smoke, because all of those things impact breast cancer. Now, having a family history, we don't pick our family, so a family history of breast cancer will increase your risk. And if you've had a biopsy and it shows a cell type called hyperplasia, you're at increased risk for getting breast cancer. If you've had cancer in one of your breasts, you're at increased risk for getting it in your second breast. If you have a period that started very early, or if you have menopause that you didn't go through until it's very late, and we used to have a number that we cut menopause at age 50, postmenopausal after 50, but we know that that may not be the case. Some women don't go through menopause until much later. So that long period of where you have exposure to hormones will increase your risk. Of course, we know that taking hormone replacement therapy, and years ago with the Women's Health Study, we determined that taking exogenous hormones, especially estrogen, increased the risk for breast cancer. And so some things you can't do anything about, some things you can. We know, as I indicated, that certain women with the family history have that risk of having the BRCA1 or BRCA2 gene, but that is really only about 10% of the breast cancers, and maybe a little bit more. So by and large, the majority of women that get breast cancer, it is sporadic, having no known factors. And so we are now, in terms of our care, and as I said, you should have a team that's taking care of you if you're talking about treating breast cancer. One, you want to get that screening. Screening will lead to early diagnosis, and screening right now is your clinical examination. I still say a self-exam and the mammogram. If you find a lump, then you have to have a biopsy and an examination, and that tissue then determines the type of tissue is there, whether it is of the subtypes, looking at those markers that we've been able to identify through research, whether you have a receptors, and these receptors are called estrogen receptor, progesterone receptor, and there's another one we call HER2/neu, which is a third receptor. We use those markers as part of our screening to tell us, to guide us in terms of how we treat those individuals. And if they are postmenopausal, there's certain therapies that can be utilized or I should say, after they have had surgical removal. We know from clinical trials what is available for those women with chemotherapy, with now immunotherapy, because we are going back to look at the genetic milieu of that tissue and doing markers to determine how can we target that therapy. And we're even getting better with our radiation therapy to target it to small areas so that you are not giving that individual increased exposure to radiation. I should also indicate, just to calm anyone down who didn't want to get a mammogram because they think they're going to be exposed to radiation, it's going to lead them to have another cancer. The radiation is very minuscule in terms of what you're getting from mammogram. And we've gone from the general mammogram, 2D mammograms, and now we're getting to 3D mammograms, particularly for those women, as women of color tend to have dense breasts. You can better outline those breast tissue with the 3D mammogram. But we also have MRIs that are there and sonograms. If you have any question on your mammogram that is not clear, that you can then go to a second type of therapy. And then you have the markers that I've said with the BRCR, BRER, and HER2 to determine what type of therapy that's going to get. And I should go back to say, for the triple negative breast cancer, it means that their estrogen receptor, their progesterone receptor, and their HER2 receptor are all negative. And therefore, the response to chemotherapy is not very good. You might get a response, but it's not a durable response. And so you have to look for other kinds of therapy. And that's why we are looking at clinical trials to get us to use the more targeted therapies that are there with the immunotherapy. And we've had great breakthrough in terms of some of those therapies, such as years ago with lung cancer, we didn't have very good treatment, but we know now with something called PD-L1, we can use immunotherapy, and we're getting a very durable long-term response for those people with lung cancer with that marker. And we're beginning to also see that with women with breast cancer.
Dr. Brown, I'm sorry. We've talked so much about immune systems and what have you in other contexts. When you say immune therapy, can you talk a little bit about, is that some sort of just what exactly is immune therapy?
Yeah, it's like a monoclonal antibody therapy that, and I can't even think of the name. I know one called Keytruda, which is, now I've blocked on that long name, but that's the brand name. And it really is very responsive for the PDL markers that we see in our cells when you do the genetic makeup. And that is important for us to have women that have that family history of breast cancer. And I should say, it's not just the family history of breast cancer, but breast cancer, ovarian cancer, pancreatic cancer, as well as prostate cancer. Those are all cancers that will respond, and we're getting the markers to know that immunotherapy may be really indicated for those individuals. There are some clinical trials that are out now looking at and comparing which therapies are best. And there are two very large ones, and you can also use these monoclonal antibodies because of the markers on the cells with some of the chemotherapy that we have in terms of response. Was there another question? I think.
Yeah, Dr. Brown, I want to go back a minute to talk about women younger than 50. And the reason that I want to talk about women younger than 50 is one of our tenets here at Black Health Trust is to not only to educate, but to empower.
Yes.
So if you are a woman younger than 50 and you discover a lump, what would you advise that younger woman to do?
Can I do a friendly amendment on your question, Dr. Neighbor? When do you start doing these self-exams to lead to that? At what age?
I would say starting on those self-exams at about age 20. You have breasts, you have your menses, the tissue is changing. Yes, the breast is really not as well defined then, but again, you also want to look at family history. And if that individual has someone in their family that have had breast cancer less than the age of 50, that person really wants to do the self-exam. They also want to talk with their healthcare provider to find out whether they might be at increased risk and you can do a risk profile in terms of looking at when your period started and when the age of the person that you have breast cancer. So the provider can do that risk analysis, but it might be indicated that that individual want to get a genetic test. Not just get the genetic test, they must undergo genetic counseling. I think many people hear, oh, I better go out and can you do the BRCA1 or can you do the PAL-B, which is a newer marker, maybe the third one for breast cancer. You want that individual to get counseling, to know what are the consequences, what's going to happen, is this covered by their insurance, and not just go in and request the same thing. So going to your question of the woman that is under the age of 50, finding a lump, must go to the provider, have some screening. I know some, and depending upon what age that individual is, if she is 40, she needs to have a mammogram. If anyone in her family had a breast cancer under the age of 50, look at the age that that individual was diagnosed. She might want to start her mammograms earlier, maybe at 35. The youngest patient that I had with breast cancer was 18. So it is important that you get some screening. And unfortunately, this young individual that was at 18 did not have a family history of breast cancer. And so again, we were not as alert to doing all of the things that we are now doing. But that individual will certainly, if now coming in and finding a lump at 18, or even pregnant women. I think in the past, we've had women, I know in their 20s, that tell their OB doctor, I think I have a lump in my breast, and they'll say, it can't be, it's just all these hormone changes, don't have to worry, it can't be cancer. But we know that women have been diagnosed with breast cancer while they are pregnant. We have also treated pregnant women with chemotherapeutic agents. Both mother and child survived doing well, although we know that chemotherapy is toxic in certain cases, and you have to look at the risk benefit for going forward. Then following your person along, they've gotten their mammogram. They then can go for that surgery, determining whether it is localized to that lump, whether they have nodes involved. And then if they need to, if they find that two things, you can go to surgery where you can have it removed in a mastectomy, but many people do lumpectomy with directed radiation therapy if they do not have any nodes involved. And if they have nodes involved, they have to do a lymph node dissection. And then you can follow that depending upon the type. If it is triple negative, they might want to do what we call neoadjuvant therapy, where they would give them some chemotherapy before surgery to try and shrink the mass down, and then follow that with surgery. And then they will follow after that.
Dr. Brown, I actually knew someone many years ago, very young, that found a lump, went into their doctor, and the doctor did the biopsy. And this is one of those situations where, what's more important, right? That's the question. Is it understanding what's going on? This person's enduring complaint from that process was that I am young and now I have a scar on my breast forever, because oftentimes we will keloid where other people will not. So has the whole getting the biopsy part gotten to the point where folks don't have to be afraid that I got a biopsy and now I'm going to have this scar? Can you talk a little bit about that?
Well, again, we have modified or updated the kind of biopsy. You can do a needle biopsy, or you can remove the lump. And again, you want to do that where your surgical technique, smaller needle, just getting some of that tissue and doing the aspirate, although it doesn't look as well as having that core biopsy, but knowing and talking to the individual, finding out ahead of time. And I should say that the care for women or men with breast cancer is really to engage that person in the care regime, so that you have a team that is taking care of healthcare providers, but also the family, the advocate, and the navigator, to make sure they clearly understand. Because you find a lump today, you don't have to get it out tomorrow. You have a little time to discuss it, to get a plan, to know what's going on, to ask those questions and get all your questions answered so that you can feel comfortable before you move on. Look at the options that are there. As I said, you don't have to have a mastectomy. You can get a lumpectomy. You can get radiation, but you can get directed radiation. So there's a team of the surgeons and the radiologists and the medical personnel. And I should say also, you want to, I know in the military, maybe we were overkill, but we had the psychiatrist as part of our team. The healthcare team had a psychiatrist and a dentist, as well as a social worker, and they were all part of the healthcare team. And then we wanted to talk with that individual. They can bring someone else with them. And I tell everyone that I talk to, make sure you have someone to help you navigate the system. You want an ombudsman. And nowadays we have patient navigators that help the patient really navigate the system. Otherwise you'll get lost. And you may come to see the surgeon here, but your radiation person is in another city, your medical person is whatever. You want to get a team, and hopefully they should be in close proximity, at least that they're sharing all of that information and answering all the questions for that individual. So she didn't tell me how much time. I want to talk about COVID a little bit. Did you have a question?
Yeah, we have a chat question.
Okay.
It's actually from our Facebook feed.
Okay.
My stepdaughter has recently been diagnosed with breast cancer and she is 38. She is getting genetic testing and has a consultation with the surgeon who has recommended a mastectomy. The cancer is in her milk gland and at a 0 stage. She has a history of breast cancer on her mother's side. Her cousin died of ovarian cancer that went undiagnosed. Her father had prostate cancer. Any recommendations for a second opinion regarding surgery?
No, it's really going to determine, and it seems like her team is following what is there. She should have asked her surgeon about the possibility of a lumpectomy, even though she said it was located in the duct or the lobule. I can't remember
She
now.
said the duct.
Okay.
In the milk gland.
Okay, in the that's, yes. Well, the lobule makes the milk and the ducts carry it out. So I'm not sure whether she's lobular. She has to get the cell type of that cancer, but talk with her surgeon about whether she is a candidate for, oh my gosh, my machine is trying to, whether she's a candidate for a lumpectomy with radiation therapy. And then it's also important, because she's 38, to know what the markers are so that that can direct her therapy. Let me plug my machine in.
Does
Okay.
Dr. Hines have a comment or a question?
Yeah, before we switch gears, I just wanted to see if we could also talk a little bit about some of the common myths about what actually doesn't cause cancer, in particular breast cancer, because these things really do hang around, and sometimes people who mean well are passing around false information, things, you know, about keeping your cell phone in your bra, or whether or not your perms and your antiperspirant. So if we could just talk a little bit about some of those common myths that get spread around.
One of the myths is that deodorant, if you put deodorant on, you're gonna then get that into your lymph nodes and you're gonna get breast cancer. I do not know any scientific studies that have linked breast cancer to the use of deodorant. So please.
There are some bad things that happen if you never use deodorant, though. They have nothing to do with cancer, but bad things happen.
Does a biopsy increase the risk of spreading cancer?
No. You can open the cancer up, and I know the myths about, well, they had a biopsy and the air touched it and it spread. No. The cancer does not spread because air is there and it spreads. It's already known. We just did not know that it had already spread. So you have to do the screening thing to really go through to make sure that you find out, has it spread to your liver? Does it spread to your lungs? Has it spread to your breast? Is it in other parts of the body, to the bone? You want to know all of that. And when you're being worked up for your therapy, they go through all of that to look to see where it is. Let's see, some of the other myths, there's something just recent about hair dyes.
Yeah.
And whether hair dye leads to cancer. No, there's not been any studies, but it's certainly being looked at now. And whether that is going to cause breast cancer, whether it will cause other kinds of cancer. We know melanomas are increasing and Black people get melanomas as well. There are some environmental factors that really will increase your risk. We talked about the pollutants that's there. We know that there are certain carcinogens. One of the things that we know, and it has not been specified whether it's breast cancer or other cancers, that I really try to tell people not to do, using those plastics that you put into the microwave.
BPAs, yeah.
And putting those BPs, even cold things, you put it into your freezer and it leaches out. Those are environmental carcinogens that lead to cancer. Whether there's a direct correlate to breast cancer is not known, but we're beginning to talk about climate change and the environmental factors that's there. So that's really important. Let's see. Now there is we talked about the myth of radiation. Years ago, when you got your radiation to treat Hodgkin's disease, you could have a corollary of breast cancer from that radiation. And now, of course, if you're diagnosed with Hodgkin's disease, Hodgkin's is a lymph node cancer. And usually it's in the lymph node starting off in the chest. And so you would get that radiation and your breast would get that. And down the line, you would have breast cancer. You may develop breast cancer. We know that some of the women that were in Chernobyl, and that's the Russian thing where they had the nuclear reactor exploded, that we saw leukemias from that and some lymphomas. Breast cancer is also a late sequela of that exposure.
Go ahead, Dr. Hines.
Just about cell phones in your bras. If you carry your cell phone in your bra, does that cause cancer? And the reason I bring it up is because there's a lot of initiatives lately around, in particular, getting Black women to run, right? And to go outside and do more exercise. And it is a common place, if you don't have pockets, right, to put, like your phone in your bra. So if we could speak on that one.
Yes.
Add to that, what if you put your money in your bra?
Well, putting that money in your bra was something that grandma did, and that helped. Yeah, she really knew where her money was, and it didn't get stolen or didn't get hijacked. So that's important. But no, the whole area of cell phones and now the limited amount of radiation, it certainly is not being looked at that I know of from a scientific study for breast cancer, but the old cell phones that we started with, the big things that you were putting up to your ear, and every few years it comes back to tell us about brain cancer and the radiation from the cell phone. It is not good to if you're going out running, you're not running for 5 hours, so you're talking about an hour at most if you run that long. Most times it's 20 minutes. So having that in your bra, but they're jogging pants that have pockets on them, so that's a better place to put it on your in that little pocket. So don't use that as an excuse not to run, because that might increase the risk. There's also one about women with big breasts and how you're jumping up and down, or somebody punched you in your breast, now you're going to get cancer. No known associated studies to say that's true. It's uncomfortable when you have larger breasts and you're running, so you have to make sure you get the right kind of garment to help control the jiggling that's there.
So Dr. Brown, one of the things you mentioned earlier about the relationship with hormones being present and breast cancer, especially for folks who go through menopause late. So the hormones are, what about hormones from birth control pills? Is there any association there with birth control pills and breast cancer?
Yes, the type of birth control pills and the uses of the birth control pills over, I think, a 5-year time period, they're seeing some correlation. And so we know that birth control pills have decreased the amount of estrogen that's in those pills so that you minimize that information. And that really came out, and always another study is always looking at that from the Women's Health Study, which is a large study, as well as from the Nurses Health Study, that they've looked at the data from exposure to exogenous hormones as well as birth control pills. And so it's looking at somehow that starting your menses early and getting your menopause late, that you have that whole window of hormone exposure, but that's endogenous hormones. If you're adding exogenous hormones on that, it might increase that risk.
Now, Dr. Brown, there's just another part of that, a corollary to that question Dr. Walsh has asked. As a senior woman, what about the hormones you take to deal with menopausal symptoms? There's been controversy about that. Some people suggest using estrogen pills. Some people are using phytoestrogens, et cetera. Can you discuss the relative risk of that? And there are also the new therapy that people are using, estrogen capsules in their muscles. And how does that affect cancer in general and breast cancer in particular?
Well, now, I don't know about the one that you're using in the muscle. I know we used something called Depo-Provera years ago that was an implant, and that had hormones that you can use over a 3-month time period.
Yes.
Whether you have now the IUDs, and some of them have been taken off the market that had their hormones with the IUD, and that sort of bleaching out over a time period may have increased the risk. For older women, and you have hot flashes and all of these things, if you're taking the estrogen and progesterone together, and that was determined in the Women's Health Study, and so that was taken off the market. I don't know if Premarin is even still around. So what they're saying is that you can use a lower amount of Premarin, as you know that the risk of breast cancer increases as you get older. So again, when you're dealing with those hot flashes, there are some phytoestrogens that you can use that have a decreased amount, but it might also, in terms of modifying your diet, to not have those soy-based products.
Dr. Brown, there is a question in the chat, which I'm going to read while you are discussing it. Simon, would you please unmute Dr. Michael Young, who has an important comment to share? The question is the 3D mammogram sufficient for checking dense breast, or is an ultrasound also needed?
The 3D mammograms are very good at determining dense breasts, but I think that you want to make sure that your healthcare provider has recommended getting the 3D mammogram, because previously in the 2D, maybe it wasn't clear and you had to get a sonogram. I think it would eliminate the possibility of needing that sonogram if you get the 3D. But and also you have to check to make sure your insurance is covering 3D. It has to be recommended by the provider, that it's something that you cannot determine what that density is, but it is very good for a dense breast. And as you know, Black women have dense breasts. So that's one of the things that our healthcare providers might recommend.
Dr. Michael Young.
Yes. How are you?
Hi, how are
Well,
you?
and you?
I just had to get in a little bit on the conversation because we keep forgetting that breast cancer, breastfeeding impacts a lot of things in women's health, and breast cancer is one of them. It can decrease the risk of those carriers of BRCA1 by as much as 20 to 30%, 24 to 30%. The feeding is cumulative. So if moms continue to breastfeed with the next person, we can actually reduce that risk in a carrier by a substantial amount. Unfortunately, it doesn't have any impact on the BRCA2 carriers. But one thing for our women, it has a significant impact on triple negative breast cancer, especially our young Black women. We see it in Hispanics as well, but for Black women over other Caucasians and even the Hispanics, it impacts triple negative breast cancer. And we can see a drop as much as 80% in that disease process, and especially important for our younger women who seem to be the ones that get surprisingly captured by TNBC. So I just want to remind people there was a purpose. The breast is there for lactation, not titillation. And when it is appropriately used, it can save.
Yes, thank you very much. I had forgotten about the breastfeeding part. Thank you for bringing that up. That is really important. And I know that it seems that the younger women now going back to breastfeeding, interest in breastfeeding, rather than thinking that, that's for somebody else to do, and I'm going to put this baby on a bottle, that would have an impact on decreasing your breast cancer, especially if you have the BRCA1 or 2 gene.
We have one last question in the chat, and I will read it in just a second, but because the people on Facebook cannot see the chat, I want to make sure that we verbally give our disclaimer, which is the purposes of our discussion of our information and not specific therapy. Please seek counsel from your own physician or provider regarding your health conditions. Now, the question was, you mentioned family history. In my younger years, I had a cyst removed and it was benign. I have 2 daughters and wondered if cysts run in families. Also, is there any data regarding cysts and breast cancer?
No, cysts are usually benign. You can have benign breast changes that's there. It's only if the tissue is defined as atypical hyperplasia. That tissue tends to then at some point in time advance to breast cancer. But cysts are benign changes that happens to be there. Some women that get them tend to get them again. Don't know of any family history of putting them at increased risk for cysts. Let's, and I don't know if there's last question, but I did want to talk about COVID and COVID and cancer just a bit before we leave, and show that the study was just recently published the middle of last year in Preventive Medicine Journal, and it found that breast and cervical cancer screening, and this is the screening that's funded by the CDC in its National Breast and Cervical Cancer Early Detection Program, that it decreased by 87% for breast and 84% screening for cervical cancer than it had in previous years. And that is quite significant. And most of that decline happened in women of color. And so I'm going to ask to have that slide put up so that we can see that in comparison to Hispanic women, the decline for breast cancer screening went down 84%, from 84% to 98% among American Indians and Alaska Native, and for Blacks at 90%. Screening was even greater in Asian, lack of screening, and this is what we're showing, this decline is 97% for the Asian women, 90% for Black women, 98% for American Indian and Alaska Native, and 84% for Hispanics. And what you see is not only with COVID here in this slide, it's just looking at what we can look at as an outcome in the pandemic for the future. Is because of this pandemic and you don't get access to care for fear of going in, you put off your screening. For those that are coming in with COVID and didn't want to get the vaccine, you're decreasing that opportunity to get that care so that you don't get the screening and detection that we're talking about with your mammograms. And so you can see that the arrow just continues to escalate. What that means is the late stage diagnosis, instead of coming in at stage 1 or 2, you're now at 4. And so the treatment has to be very different. And many times that means that you also have a delay in your treatment because you didn't get the screening and now your mass is larger and you get in, and because COVID beds are full, or your healthcare provider can only schedule your biopsy and your surgery, there's not enough room. So that delays the whole process, and you're going to see an increase in your cancer mortality rate. And we know that those things that put us at risk for COVID are the same things that put us at risk for cancer. And so we had a study that was done by the American Society of Clinical Oncology last year, and it showed that 2/3 of Americans delayed or skipped their screening, and that is all males and females. No mammograms, no colonoscopies, no pap smears, no HPV testing, and you're in this really pandemic, and so we really have to talk up this to our population that it is time for you to get back on the screening. This month for breast cancer, call your buddy, tell somebody, did you get your mammogram? Schedule that mammogram, schedule that colonoscopy. We are dying from all of these things: breast, prostate, lung, colorectal. and I should add pancreatic. And if you're in that category where you might have a positive gene, ovarian, prostate, pancreatic, and breast tends to run in those families. And that might mean that you have one of the genes that are there. So get tested, know what's going on so that you can then decrease your likelihood of succumbing to this disease and increase your survival so that nearly 4 million people that are surviving or thriving from having a diagnosis of breast cancer, we want to increase that number in the future to keep our lovely faces here on earth.
So,
And
while we're talking,
so Dr. Brown, I'm sorry, go ahead, Dr. Hines.
oh, sorry. While we're talking about prevention, can you just to kind of explicitly address whether there's any relationship between vaccinations and increasing your likelihood of a cancer diagnosis? Obviously COVID vaccinations, but in just the general standard vaccinations that people are supposed to be getting. Is there any relationship between those and increasing your likelihood of a cancer diagnosis?
No, there's a likelihood of preventing a cancer if you get the HPV. That is known, cervical cancer, and we also think, oh, that we've taken care of that. We don't have cervical cancer, but we are seeing a rise in cervical cancer. It's important. It's a vaccine that is available for both males and females, starting at age 12 or 11 on up. And now even those, because you really, ideally, we wanted people to get that vaccine before they became sexually exposed to the HPV virus. But again, if they have not, you can still get the vaccine in your 20s and beyond. So that one is preventive. So not that any vaccine that I can think of has any correlation to development of cancer. And certainly the COVID vaccine is not in that category. We have the VIRS and we have the V-Safe. If you're getting any kind of things and you think it's related, let us do this. We do not know the long-term effect from the COVID vaccine because, hey, it's only been on the market for what? Less than 2 years in terms of the disease. And of course, the vaccine has an even shorter time period. It is being monitored. We're collecting data. We really want it to be there. And so again, and that's why we have the V-Safe. You can do it on your smartphone, and the VIRS to tell your provider about any symptoms that you might have so that we can track that data and know what's going on. But no, do not have any relationship from that. You're more likely to be exposed to something in the environment that's going to give you a risk for cancer.
So Dr. Brown, I have to stand up for my fellow XY people, for the men. You mentioned men with breast cancer earlier, and I remember doing a health event with Richard Roundtree, the original Shaft, not that Samuel L. Jackson guy for you younger people. And Richard Roundtree spoke publicly a lot about his own breast cancer journey. And I think one of the important challenges for men is no man wants to have breast cancer. You know, you kind of look at that as something women have, but it didn't impact Richard Roundtree getting more macho man roles and that kind of thing. And so I think it's important for us to recognize, as you stated, that men can get it. But what are men supposed to do? We don't, nobody tells us to go for routine mammograms. And so are we doing self-examination? Just a little bit about what is it men should do and how do we protect ourselves? Because we can get breast cancer.
You can get breast cancer, and some men have breasts that they can get a mammogram done. But you can also do sonogram for those men that's there. And if they are in a family, as I said, where your risk is really high, then the likelihood that men that have breast cancer are at increased risk of really having the BRCA gene. So that is one thing that you then want to really be careful about. But you can palpate your breast. And then if you find something that is abnormal, you want to make sure you bring that to your healthcare provider. And as I said, the sonogram, and in some cases, even a mammogram. So, and I know some women will say, so now they can see how they feel in that machine. No, that's, again, you can do the 2D or the 3D mammogram so that it can be yes.
I was just going to add to that question you bring up with males. There's been research to show that soy protein can give gynecomastia. People who use tetrahydrocannabinol, also known as cannabis or pot, can get gynecomastia. And males with an extra X chromosome can have an increased risk for that cancer also. If you could just discuss that for a moment.
What is gynecomastia? Dr. Maxey, can you please stop using those $5 words?
That was a $7 word. It's increased breast size that can happen not only with obesity, but with soy, with pot smoking.
And some of the medications that we psychiatrists prescribe can have a gynecomastia side effect as well.
Yes. Yeah. And again, that increases the importance of why those men need to really kind of palpate that tissue to make sure that they're not finding a lump. But generally, as I say, it's because of the soy products that's increasing their hormonal milieu. And particularly if you have one of the abnormalities like Klinefelter's, I think is the one with the extra chromosome that, again, may be at increased risk for having a cancer.
Well, I've got a delicate
maybe also testicular as well as the breast.
So this is a question for you with a reference to Dr. Walks as well. For people of transgender who take hormones to feminize themselves, does that increase that risk of breast cancer?
I think, again, we are just learning in terms of the individuals that are going through the trans surgeries and getting the hormonal therapy to they need to be watched and screened as well. We don't have as much data as we need, so it's important to do the studies and look at that in our LGBTQ community where we are getting data to look at that. But certainly needs to be under observation to find out if that risk is going to be increased. We don't have data right now in those categories.
Thank you. We certainly appreciate what you brought to the Black Health Trust today. And one of the things that Dr. Wilbur Jordan, one of our medical advisors, has consistently brought up almost every week is that we don't have the habit in our communities of people having primary care doctors. And we know that primary care doctors are charged with doing this screening. Now, Dr. Hines, you have done some primary care work. What can we do to really get people to get these screenings by having a real primary care base, which is based on prevention? I'm concerned about that.
I think some of the educational campaigns that we've started within our community, like, take a loved one to the doctor day and things of those nature, they are actually very helpful and effective. It was interesting because a lot of the myths that Dr. Brown was discussing, in my personal life, I've heard almost every single one of those things I have heard someone either say to me or passed around between friends. So I think that, and we saw the same kind of example with COVID, the importance of peer communication and within our community, educating our community about what needs to happen, which is why I think those campaigns where you use your family, your friends, the people that you trust to get you to having a primary care doctor and those kinds of things. Oftentimes I think what happens is people get caught up in sick care, right? I'm seeing this doctor for this thing, and I'm seeing this doctor for that thing. And you kind of forget that everything's not being taken care of. And in particular prevention, because lots of times if you have other illnesses, you can be oftentimes overwhelmed with the disease processes that you're managing, that going to go look for others or to go screen for others is overwhelming. It's overwhelming to think of yet one more appointment. The other thing too is amongst our provider community, sometimes I think that we also have to let our patients know, hey, I am not a replacement for your primary care doctor. We may have a close relationship. I may see you on a very regular cadence, but I haven't taken on responsibility for making sure that your mammograms are getting done, colonoscopies are getting done. And sometimes I think on the provider side, we don't have those conversations with our patients.
I know certain women, some of them I'm related to, whose only doctor is a GYN doctor. That's all.
And that's very common. And if your GYN doctor, and if you've had that conversation, so there are some GYN doctors who are willing to take on that kind of primary care role up into a point, right? And if you've had that conversation about those things, some people will do that, and that's okay. But then there's a space for if your constellation of diagnoses goes outside of a certain realm, then that same doctor is likely to have to say, hey, we've gotten this far, but now it's time to shift your care of some of these other conditions to a primary care person. Like I said, it's largely, as we talked about before, even during this conversation, discussing roles and discussing relationships and what it is that you want. And on both sides, not making an assumption like that just because I'm seeing this specialist, just because I'm seeing my gynecologist and they check my cholesterol and they're checking my mammograms, oh wait, did they also tell me to get a colonoscopy? Or oh wait, are they doing some of the other screenings that are age related or disease specific, for my conditions? Maybe they are, but maybe they aren't.
So just to repeat this, and it seems that when we first started Black Health Trust, every week we talked about diet and exercise. When a person goes to a doctor, what should they expect? Primary care doctors, what are the things we need to do, Dr. Brown and Dr. Hines? What do we need to make sure they do? You mentioned some of them like colonoscopy. What should be done by us going to a primary care doctor on an annual basis or a 5-year basis?
Yes.
What should be done?
I think on an annual basis, and it doesn't matter who your provider is, you need to make sure that, again, you want to know your numbers. So first of all, you got to know what your cholesterol, you want to know what your glucose, in many cases, now we're going to A1C. Then you want to also, for women, you want to know what your thyroid, you can get your TSA. That's also important because women, as they get older, tend to maybe go through some decreased areas and talk about depression and all of this, and we don't really screen as much for that. That's really important. You want to get your mammogram, you want to get your colonoscopy, you want to make sure that you have all of your vaccines done, and that is your flu. If you're over the age of 50 or 55, you got to get your shingles. You want to get your Pneumovax. I think that's at 65. There's a whole list of things that you need to do. And I should also say, importantly, because we don't talk about this enough, for Blacks, you need to get a screen for your vitamin D. Vitamin D is associated with many of the chronic conditions that we have and may help us to increase that risk for cancer. So just know that what is your vitamin D level, and then it might be that you have to add that in. You want to get your eyes examined because diabetics have problems with their eyes at some point because, again, these chronic diseases. And so I think that is every 2 years that you're going to get your screening for your eyes. You want to make sure your kidney functions are okay. So at some point, somebody has to do a urinalysis to make sure that your creatinine, BUN, and all those things in terms of your blood work is going to be good. And also as an adult, I know when you're a child, you get all that pertussis and or DPT, and then as you get older, it's called the Tdap. Okay, I'm trying to remember what it was. Tdap. Yes, so all of those things are there. As you get older, You might also want to get a DEXA scan. Because as you get to that really senior level, you're more likely to get that bones broken. And so that's, again, knowing what your calcium and vitamin D levels are. So you might want to get a screening to look at the DEXA scan to see your bone fragility. Did I miss anything? And then the dental exam, you should be going at least once a year, if not more, because that is really important in terms of bacteria and all of the things that's there. And then you got your mammogram, your colonoscopy. For young men, you got to, whereas part of your physical exam, they should do a testicular exam. Doesn't happen as much in Black men as it does in non-hued men, but testicular cancer for those young men tend to be an issue. And so you want to kind of feel that.
And the prostate.
Oh, yes. Well, men need to get the prostate exam, very much so, and get the PSA. So that's, we say at age 50, but you might have to start a little bit younger if you've had prostate cancer in your families. And we didn't, years ago, they used to do chest x-rays on everybody. You come into the ER, you get a chest. They don't do chest x-rays anymore in terms of that screening tool. But if you're having respiratory symptoms, if you're a smoker, and I certainly hope not, it's just makes you cringe to see people smoking nowadays, that you might want to get a screening CT for lung cancer. So those are the ones that I can think of. I hope I didn't miss anything. I tried to go from the head down.
Yeah.
And if you're feeling stressed, I suppose we can see Dr. Walk to get a mental health assessment. They always ask, do you feel like killing yourself? I don't know what the question is, but are you feeling depressed or down? Do you don't want to get out of bed, or you do whatever? It's sort of a mental health screening should come along. And it seems like we need it nowadays more than ever, since I'm finding all these people that are shooting and just doing crazy things. So I think we need to have a mental health screening every 6 months, because it's out of hand.
So let me just say, Dr. Brown, one of the questions is, do you feel like killing yourself? And in all seriousness, all primary care providers can actually download mental health screening tools that they can use. And I think when someone comes in, I know Dr. Hines is the family practice expert, but I think because people see family practice docs or GYN docs or other folks so much more often than they would go see a psychiatrist, I think it behooves us to as docs, period, to do what you just said, Dr. Brown, do that comprehensive screening, and don't forget that. One thing I'll add quickly while we're talking about this, when we see folks, in addition to the screening, looking for something that's wrong, I think Dr. Hines brought this up, help them do the things that'll keep them healthy. It is everybody who says to me, one of these days when I have time, I'm going to start to exercise. I say the same thing. I say, no, you won't. No, you won't. You have to make time for things like exercise, things like staying flexible so you don't pull a muscle every time you reach for a cup, things like working on your balance so you don't fall over every time you're trying to do something. There's a lot that we can take just a moment to talk to people about to help them stay healthy. And I'm pretty sure there's still a lot of those little pamphlets that are put out by different parts of the federal government that you can have in your office to hand someone or send a link to someone to download on all of the ways we can make our bodies able to move and stay healthy.
Yes, movement is life. That's two things that I do want to add that we haven't talked about. Sleep is important. We as healthcare providers are really horrible with this. 7 hours of sleep, and it was like, oh, I couldn't possibly do that. And you hear people saying sleep adds to some of the chronic conditions that we have. And so you really want to look at, it's like you'd have to put your body in a refresh mode. And that refresh mode comes from sleep. really important. Just try to increase that amount so that it's good for your blood pressure and all of the things that's there. And the other one is when you talk with your healthcare provider, and if you don't have one, please, everybody should have one. Look at your medicines. There are some interactions because you go to Dr. J over here and Dr. Q over there, and they prescribe all of this, and then you don't tell them you're taking this other little white pill or this little blue pill. You have to let them know what you're taking because you can have some interactions. And so it's really important to make sure that you list even the over-the-counter medicines that you're taking with those that are prescribed for you. And then throw in all of the things that you're getting from the CBD place as well.
So we're going to soon do a program on primary care. But Dr. Barbara, can you review our stats real quick? And I want to do a couple of videos and announcement of our upcoming program. Dr. Brown, you have brought so much. We thank you, thank you, thank you. And the colonel is pretty close. Is the colonel higher ranked than the general?
No, the general comes after that. You're the general of pickleball, paintball.
But I think colonels run the operation more so than the generals, right? The generals just sit on a...
They just wear all the stars.
Dr. Neighbor Stevens, would you give us our statistics?
Well, I'm going to give an abbreviated quick rundown. So far as of last night, we have experienced 45,316,210 cases of COVID.
45 million?
45 million.
Oh my goodness.
11% of which occurred in African Americans. We have had 733,834 deaths, 13.9% occurring in African Americans. We have had a total immunizations of 412,856,169. We have
Wait, let me ask another question right there. Is there any scientific evidence that of those 400, how many?
12,856,169.
So I had a patient tell me the other day that 44% of everybody getting the vaccine has died. Is that true?
I don't think so, since we've only had
It can't be.
733,834 deaths from COVID.
So that's bad information, right?
That would be bad information.
Okay, keep going.
Well, that 412 million total doses administered means that we've got 66.3% of the US fully vaccinated. However, we're lagging behind. We have 10.6% of all African Americans with at least one dose and 10.2% of African Americans that are considered to be fully vaccinated. That number hasn't budged. That number really hasn't moved.
Can I add something to the statistics, Dr. Neighbor Stevens? I live in the DC area, and I'm personally hurt by these statistics. I don't understand. The DC Department of Health reports that of all of the COVID deaths in DC, 77% of them are Black folks. Now, DC used to be Chocolate City, and the majority of folks used to be Black, but we are no longer the majority of people in DC. But 77% of the COVID deaths in DC were Black, most in Ward 7 and 8, where a lot of us live. And then from June until now, 50 people, as of last week, 50 people in DC died from COVID between June of 2021 and last week in October. Of those 50 people, 49 were Black.
And were they unvaccinated?
Well, that statistic wasn't there, but we know from every other statistic that we see that it's primarily folks who are unvaccinated. And I just, every time we do these statistics, every time we talk about this, I don't know what else to do other than to continue to let people know that it is not necessary. I saw something on TV, some unvaccinated people that the mom and the dad died, and the sister who is vaccinated because the parents were not, is now taking care of their 4 kids. I mean, come on. How, I'm sorry, I'm about to go off and I'm gonna leave the preaching to Reverend Pointer, but it is so painful to me to know that our community continues to struggle with this when there's so much good information about the safety and the efficacy of the vaccines, and we just need to do better. I'm sorry.
No, that was very appropriate. But Dr. Barber, can you give the actual website that we get these statistics from and that has all the guidelines that people can go to?
I just go to the CDC website, www.cdc.gov.
Can you put that in the chat if you would? That would be great. Simon, I'd like to show a 2-minute video that Mr. Dorsey has of something that we can use in our jobs and homes as a product. Could you cue that up, and then we'll have some final statements. Well, he's queuing that. Barbara, any questions in the chat that we didn't get
No,
to?
we covered everything in the chat. And in the interest of time, I would just like to say, we are in the next week anticipating announcements regarding vaccination protocols for kids. Please stay tuned, and we will certainly be discussing that in the upcoming show.
And I'd like to apologize in advance to anyone who I push out of the way as I'm rushing to get my booster shot for my Moderna, because as soon as I can get there, I'm going to be there in the next couple of days. So either run fast, or I'm sorry if I push you out the way. I can't wait.
Man, you're late, man. I got mine 4 weeks ago.
I'm trying to follow the rules, Dr. Maxey.
Okay, Simon, you can't find that video? Okay, we'll show it next time. Again, Dr. Brown, thank you.
Yes.
Dr. Hines, thank you. Dr. Neighbor-Stevens, thank you. And Dr. Walks, thank you. On the 21st, we're going to have a special program on heart disease, especially heart disease called amyloidosis, HATTR. It's going to be one of our first sponsored programs. We've got wonderful speakers planned, and we are growing at the Black Health Trust. And also a week from now, we want to do return to our medical advisory meetings. Thank everybody for participating. Do my co-moderators have a final word? I guess we don't. Have a good day, everybody. Dr. Pointer, would you take us out? Is Pastor Pointer unmuted?
Not yet.
You got that big old bridge.
There he is. Reverend Pointer, we still cannot hear you, even though you're unmuted. Now you're muted again. The technology. There we go. Yes, sir.
Okay, God bless. Dr. Brown, we were really blessed by your presentation today. This is an issue for me because I live in a city where we have a comprehensive cancer institute. So I'm always talking to those scientists around these issues around Black men and women with breast cancer. So we work consistently with the Roswell Park Institute and in our churches all month long. we're talking about breast cancer in African Americans, male and female. So thank you. This was really informative, and I was, while you were informing us, I was sending out information to the members of our congregation. So thank you again. Let us ask God's blessing as we look to close another really excellent Black Health Trust. Holy and everlasting God, the Father and maker of all that we know and see, the one who gave us your only Son, that we might have a right to the tree of life. We thank you for this time of sharing and a fellowshipping together. We thank you for your servant, Dr. Doris Brown, and we ask, oh Lord, that you'll continue to bless her in her work, that her hands would be guided by your loving care, that as Black Health Trust, and we continue to bring information and to infect this community with information, that it will spread like the pathogen has, so that every man, woman, boy, and girl in this community can be more informed about their own health. And as we seek to do your work here on earth, we ask, oh Lord, that you will strengthen us, that you will give us sound mind and bodies, that you will strengthen our psyche for all of the adverse conditions that we continuously find, and that we, layer by layer, will eliminate health disparities in our community. We pray and thank you for all that you have done for us and that you will do. We ask these blessings in the name of your Son, Jesus of Nazareth. Amen. And thank God. It is a blessing to be with all of you.
Amen.
Thank you, Pastor. Have a good day, everyone.
Yes.
Bye.
Stay
Bye-bye.
safe, everyone.
Yes.